All right, we are back with another one. Welcome to the Survey Readiness Podcast. I am joined today with my co-host. Ms. Veronica Caesar, CEO of Gym Healthcare Consultant. Veronica has an MBA, a master's, an LNHA. She's known for MDS reimbursement, and she's an expert that works directly with buildings to help them with their risk and compliance. You already know me. I need to introduce myself. But today, we're talking about reevaluating. We're going to evaluate plan of corrections. One particular tied to F689, accidents and supervision. And our F tags of the week, usually we do one. This week we actually have two because it makes sense to really combine them together. And we're going to talk about F790 and F791 because what looks like a fall in supervision often appears as F689 accidents, which looks like what looks like a resident doing normal stuff often comes up under 689 accidents and injuries. So, Veronica, how you doing today?
I'm great. Good morning, good afternoon, depending on where you are in the world. I'm excited to talk about oral care, dental care, because it's often overlooked, right? It's very much so can be overlooked, but oral health is so important because in nursing homes, it can be strongly linked to like pain, poor intake, weight loss, and also overall lower quality of life. And actually last year I was reading some studies where they linked poor oral health with higher risk of Alzheimer's disease, as well as aspiration pneumonia. And so we think of why are our residents keep getting sick? Why do they keep getting pneumonia? And so we really need to take a strong look at oral care in F790 and F791.
You know, it's interesting because I think oral care, I don't want to dive too deep into it, but I think oral care is often overlooked. I was a certified nursing assistant before I became a licensed practical nurse. And that was one of the things that was stressed to me in Detroit, Michigan, when I was becoming a senior was you got to do oral care because it leads to good overall health. So that's why we selected those today because it's not talked about. But before we dive into it, let's talk about the last 2 weeks, right? We've got a lot of great feedback on the podcast, so we're going to continue this. This is officially episode 2, tooth tags and Tracebacks, dental services and F689. You're in a building, you're overseeing buildings. What are you seeing? What are you hearing from surveys? What is it like out there?
I feel like I said, we kind of touched on this last week, but care planning is a major focus. And then, of course, your required notices, NOMNICs, ABNs. I feel like a lot of surveyors are also looking at our processes. So, of course, a lot of just compliance things. And so even before they get to the care and observation, they making sure all of your paperwork is in place. And if that's not in place, when they go see what's out, in the facility, it's definitely going to set you up for failure. So,
and I would be remiss before we dive deeper to talk about our sponsor for today's episode. I'm just going to roll the clip. Today's sponsor is brought to you by Gym Healthcare. Did you see that? Did you like that? Where you are the owner of Gym Healthcare. So talk to us about Gym Healthcare. What do you do and how do you support organizations before we dive too deep into this?
So Gym Healthcare, I am the principal consultant, CEO. We have a polished approach to skilled nursing, post-acute care. So all things compliance, reimbursement, quality over everything. So that's one of my major drivers. I work with facilities on quality measure improvement plans. I'm actually getting more into the education piece. If you guys follow me on LinkedIn, I'm always posting educational
ebooks are amazing
topics. I have a free ebook on the website. So if when you head over to veronicacaesar.com, you'll be able to see the free Survey Readiness 12-week compliance roadmap. It's a free ebook. I've been getting a lot of good feedback from it. It has practical real world examples of facilities that I've worked with, consulted with, how they've taken some of our QAPI tie-ins, because QAPI is very important, and use that to really improve their survey readiness.
And we definitely going to talk about that because to your point, right, QAPI is a major thing, and QAPI is going to show up in the POC we're reviewing. QAPI is also going to show up in the dental care that we're talking about. But one of the things that people may not know, and which I recently learned about you, is your what do you call it, a gold examiner, or what's your
Yes.
new role? What do you got that's helping organizations moving forward, and why should they know about it? And this is
So
not paid by AC. I forget say the initials. We're not sponsored by them. We'd love to
ACA,
be,
American
but
Healthcare
yeah,
Association.
we would love to be sponsored by ACA. But yeah, talk to us about it, because I think it's important for organizations to understand how to strive towards excellence.
Well, the journey towards excellence, you there's no losses even if you don't reach a gold level. So there are 3 levels of quality, and so most facilities start off at the bronze level, then move on to the silver level, and then the highest level is gold. And so I'm a gold quality examiner, where we review applications. We use the Baldrige framework for
Yes.
quality improvement, and so it's inspiring and seeing the facility's journey from bronze level to silver level to gold level. And like I said, even if you don't get the gold award, just the process of refining your facility's processes, evaluating them for improvements, sharing best practices, sharing refinements, all of that. Even if you don't, make it to a gold award, the process is rewarding in and of itself. Facilities learn a lot about their internal systems, they learn about areas to improve. And at the end of the day, that improvement is going to trickle down to the residents. And of course, the residents are the most important thing.
And you say residents are the most important thing. We should treat residents like the most important things. We have to provide care for our residents, and we have to provide safe supervision for our residents. And that's going to lead into our plan of correction of the week. Each week, we review a plan of correction. We discuss some of the things that we are finding with that we saw in the plan of correction. We're going to provide feedback on what we may have or could have done if this was our plan of correction. This week, plan of correction is one that I found online, and it deals with my favorite topic. It actually deals with elopement and facilities responses during an elopement. This plan of correction is online, so people can find it is they're on Nursing Home Compare. So you can definitely, if you're snooping enough, can figure out what it is. But for what it's worth, here it is. I've kind of summarized it on a screen for us. This was a resident with dementia who successfully eloped, crossed a few lanes of traffic, went over to a nearby gas station. And this infographic actually discusses a little bit more in detail, and we're going to walk line by line about it and talk about it in the facility's corrective action response. Let me be clear. I've had this happen to me. I got my first IJ as a brand new administrator 3 months in.
Oh, wow.
Yeah, it was an elopement at 4 o'clock in the morning in February. Yeah, yeah. Have you dealt with an elopement? Have you had one as a nurse consultant, as administrator? Have you had one?
I've had one as a DON, and yes, you get that phone call and your heart like literally drops. I mean, literally drops. And the location of our facility was, of course, across a busy street as well. And there
It
was a
was
park across the street. And so a lot of our residents,
yeah.
yes, yes.
It's my facility was a block away from a 6-lane highway. Very busy mile street, and we had an elopement in winter, and this resident was dementia, and it seems to be the case, was able to leave the facility through secure doors that were alarmed and walk across these highways. And what was interesting is that when she got to her destination, they realized she shouldn't have been there, and they called EMS, and EMS brought her back. When they brought her back, our security guard said, "We're not missing any residents."
Oh my goodness.
Mm-hmm. So to my administrators, DONs, you're not alone
Right.
out there with these elopements. There are solutions in place. Actually, I'm working on an immediate jeopardy manual, free ebook to give out to people to help them, because I never want somebody to have to go through what I went through. But I think the most important thing administrators can do is stay calm and lead the team during that time. I think
Yes.
it's key. I mean, you said it, stay calm. What was it like for you with your IJ, or with your elopement rather?
Um, that was my very first DON job. I had a new
Why is it gotta be like
administrator.
that?
Yeah, I had a new administrator. It was just we had a lot of agency in the building. The population was definitely behavior, dementia,
Mhm.
all of that mixed. And then of course, we had like younger population. So with a lot of agency staff in and out.
Yep.
Some people didn't even recognize or understand who could leave and who could sign themselves out and who could not, right? And
Yes.
so the gentleman that eloped probably was in his late 50s, and he could look like a visitor. He could look like a staff member,
Yep.
right?
Yep.
They're not walking around, or this person was ambulatory. And so, he wore regular clothes. It wasn't like he was in gowns and,
Yeah.
just so exactly. So it was just a lot of miscommunication, a lot of misunderstandings, and just an avalanche snowballed into that. Yes.
And it's interesting because same situation with me. This patient was ambulatory, didn't look like a patient, but if you talk to that particular patient for anything greater than 30 seconds, you'd realize that was a patient. And so it was heartbreaking for me to learn that my security staff didn't understand that this was a patient. And it all came back to training.
Yes.
The training that a facility had of how to handle elopements and what to do after elopements. With me, it was my heart sank. I got an immediate jeopardy. My first immediate jeopardy 3 months in. Did you end up with an immediate jeopardy for your elopement?
Yeah, we did have an IJ, yes.
Oh my God.
Yes.
It's not, and administrative, we don't talk about it, but we get IJs. People, everybody want to keep it. You will get an IJ in your career. I hope it never happens.
Right.
But they can, an IJ is not about actual harm.
Mm-hmm.
It is about the perception of harm, the perceived risk of harm.
Yes.
If there's a potential for risk, you will get an IJ. And I think people fail to realize that. They think, I had to be harmed. That's not the case.
Right.
It's not the case. So when we look at these immediate jeopardies, and I see it over and over and over again, and I'm explaining to administrators, especially as I'm writing abatement plans, and we're going to get to that because you got to learn how to write an abatement plan quickly.
Yes. Yes.
And immediate jeopardy is $10,000 a day. Yes. It's $10,000 a day. So, as a DON, what were some of the interventions that you put in place in that moment to help navigate through that IJ?
So we definitely updated an elopement book, and we positioned that at the front desk.
Yeah.
Also in our sign out book, we had a little a sheet with like the names of elopement people. So if I'm a staff member going to sign or assisting a resident to sign out, is this resident capable of signing out? And so I think we had a lot of residents there who could sign themselves out. Yeah. And so a lot of our staff assumed that every resident could sign themselves out. And so while we were assisting people sign themselves out, but if you have a BIMS that shows, moderate and severe cognitive impairment, then that person isn't able. And so we had to do a lot of in-servicing. I mean, actually, we partnered with the agency because we were using so much agency at that time. And so the agency had a way to provide that in-service, and then we were able to only use the staff who had completed our in-service. And so if they weren't on an approved, use list because they hadn't completed our in-servicing, then we weren't using them.
It's interesting because you brought up something, and that's not the purpose of our conversation, but I think it's important we talk about it. We bring agency staff in our building and give them absolutely no training. We expect them to know how to handle a fire drill, a fire, elopement, reporting abuse. Are we setting ourselves up by just bringing these agency people in our building and not offering any training?
I think so. And then the first thing we're going to say is, well, the agency should have trained them. But, you have these temporary...
They don't know our policies.
Yeah, exactly.
They don't know our procedures. They don't. It's such a risk. And I think we don't talk about it, but it's a risk when we just bring agency staff in the building and say, go to that hall, and didn't even orientate them to the Cardex.
Mm-hmm. Yes.
And yeah, it's we can do better as leaders with it. But let's get into this story. This happened sometime in July of 2025, where this resident with dementia crossed X amount of lanes, 4 lanes. What I saw in the POC, which was interesting, and I've kind of highlighted it here, at about 1 p.m., they returned from actually smoking outside. Let me see if I can draw on this. Let's see if it's going to allow me to do it. It's not going to allow me to draw. They returned from smoking outside, and the staff lost visual contact of the resident shortly after. At about 1:25, there was a missing warning. The door alarm sounded. Staff reset it without verifying the cause or performing a head count. Man, that happened to me. Is
Yes.
this me?
Yes.
They didn't follow the procedure.
That alarm fatigue. I actually did a study on that.
What is alarm fatigue?
We just hear all the beep beep beeps and we get immune to it. We hear the door alarms. We hear when some facilities still use, those fall pressure alarms, the tab
those
alarms,
Yeah.
the IV pump alarms, the tube feed alarms. And so what started off as a way to alert staff that something is going on, the longer we work in these facilities, in these areas, we're able, even a call light, we're able to tune it out. Right. And so you hear it going off. Oh, somebody, it probably was, the CNA coming in. She never can remember the code, or a family member going out. I'm just going to hurry up, tap, 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 turn the alarm off. And like you said, not do that follow through, not just open the door, look outside and see if there's somebody on the other side of that door. That should not be.
Ooh. And so we just turned off the alarm in my facility and we went on about our day, because nobody would ever escape at 4:00 in the morning at my location. No, nobody would do that. And then at about 5 minutes later, the maintenance director discovered a resident unsupervised at the gas station and crossed 4 lanes of traffic. Wow. So much could have happened there with that resident crossing traffic. Imagine if the maintenance director didn't discover him, what could have happened?
Mm-hmm.
It's interesting because when a state comes in to do a review, they review your notes. They don't just look at that day. They look at patterns and they look for trends. Am I correct?
Yes.
In this particular chart, I don't know if you, or POC, I don't know if you had a chance to look at it. It talked about on July 14th, the care plan was updated, noting the resident requires supervision for locomotion. Then on the 16th, the social worker reported attempting to push open that front door. Is that not exit-seeking behavior, according to them? Is that not? I mean, what's your thoughts?
Yeah, definitely exit-seeking. Yes.
And then the resident elopes on the 19th, 30 minutes after, or the resident elopes 30 minutes and then subsequently moved to a secure unit. My resident escaped from a secure unit.
Wow.
I'm not laughing because it's funny. Right. It's just our solution is a secure unit, as if it's going to always be the solution. But if we haven't shaped processes and processes and policies, you're going to have the same thing. Alarm fatigue doesn't go away because they're on the secure unit.
Right.
So this particular plan of correction, they did some clinical interventions. They did 101 for 15, or 101 with this resident. Also did facility-wide training. How important is that retraining during this process?
It has to be 100% retraining. I mean, literally 100%. And so a lot of times I find that facilities will do an in-service with whoever is there that day, right? They don't wait for the next shift. They don't do it. You have some people doing weekends only. They literally will do, okay, this happened on Wednesday at 7 to 3. We're going to in-service out of 7 to 3. We may in-service the incoming 3 to 11 staff, but are we then circling night shift in? Are we then making sure that we're doing weekend people? And then if we have consistent agency people, we might have an agency person who's under a certain contract, making sure we're pulling them in. Then not only nursing, right? We gotta be in service and dietary, housekeeping, activity people, the volunteers that come in. This has to be literally a 100% in service, because what if it's a volunteer coming in and they open the door for a resident, right?
And say, "Ooh, let me get that door for you," as they walk out. That has happened. I'm like, no, they ain't not volunteer.
Yes,
they not guests here. Yes. They live here. Close my door back. Don't do that. And so it's important to train staff to be aware and be vigilant of the residents that are potential elopement. But something that you called out earlier, I think we need to talk about too, because my keynote, which is coming up in just about 11 days from now, talks about NIJ when we got an elopement, and from residents that weren't demented. Because you can get an elopement for a resident who was alert and oriented time 4.
Yes.
You can still get an elopement tag it is still harm. So I talk about that. And so when I'm talking to my leader, to my team, you got to train everyone, and especially your security people who are supposed to be watching the door. If this person's annual times 4 and they leave, did they sign out? Do we have a physician order? Because that's where it really
Right.
we get to it. That's where it counts. That physician order. We
Right.
got to have a physician order for this person to leave. They can't just. It doesn't work that way. They're supposed to be receiving care, especially if they're, Medicare, Medicaid. There are processes and procedures that we should have in place if a resident is deciding that they want to leave.
Right.
I always tell people, you're free to leave. This is definitely not a prison. We just have to follow our policies and procedures if you're going to do that. So if we say we're going to notify your guardian, if we say we're going to notify the ombudsman or whatever, we have to do that because we're held to that highest standard.
I'm glad you said that, because literally knowing your policy and procedure and following that's where a lot of breakdown happens, because they'll say we did X, Y, and Z, and then the state will say, let's see your policy and procedure.
Yep.
And half the time, they may ask your frontline staff, what's the policy on this? And they'll say, I don't know. And so just knowing the policy procedure, all of your staff knowing it and following it, that's where I see a lot of the bad things happen.
And so when we talk about policy and procedures, everybody has to be aware of them. I think it starts in orientation, new hire orientation. You got to share them. Like you got them. Tell them what your expectations are. That means you need to have a structured new hire orientation. Don't mean you can't just throw them to the floor. I mean, speak. Let me know if I'm wrong. Stop me.
We are literally revamping our orientation process now. So yes, I totally agree with that. Yes. And then especially talking about using our facility assessment to talk about the demographic of residents we serve, right? Every home is different. And so even in a corporate type of, every facility may serve different residents, right? And so like this facility that you use the POC for, it said that they had a secure unit. And so if you're serving those type of residents, are we educating in orientation about caring for residents on a secure unit, about the policies and procedures on coming on and off of a secure unit? So definitely the orientation piece is definitely important.
It's important and it's vital because we are dealing with patients' lives. So everybody has to be on the same page. So I think when we talk about this immediate jeopardy, I never want an administrator to get it, but if you do get it, I want you to be prepared for it. And that's why we're talking about our immediate jeopardies openly. This is why we pull down plan of corrections each week and we discuss what we're finding with the plan of corrections, because we want you to make informed decisions when the time comes. They don't train you for writing an IJ in school. I teach at the collegiate level. I teach MHAs, people who are getting their masters in healthcare administration, their bachelors in healthcare administration, and they're doing a concentration in long-term care. We don't teach how to write a plan of correction, but on this show, the Survey Readiness Podcast, we talk about it. So before we switch over to the F tag of the week, I want to talk about our second sponsor for the video. I would be remiss to not talk about our second sponsor for the video, and that is Survey Guard. Survey Guard is the AI compliance platform of choice for the post-acute care space. I'm not showing it on my screen. Hold on. It's here. It is the AI compliance platform of choice for the post-acute care space. So after dealing with IJs, after dealing with buildings that were struggling with QAPI, I decided to do something about it, because you and I both know we can sit around and complain about it all day, but are we going to do something about it? Right. And that's what I decided to do. So with Survey Guard, it has mock survey features in it. It allows you to prep for survey. It has every single pathway that you can think of built in, and additional pathways as well. Book a demo to talk to me about it. It also has Guardian Angels, customer service rounds, right? That's what Guardian Angels is at the heart of it. It handles your grievances. It will manage your audit process, and it will write your POC faster than a Jeopardy song will play. If you value time, this is the solution for you. But if you like to do things manually, maybe this is not the solution for you. We're here to help you ditch the binders. And that's my spill on Survey Guard. You can visit us at surveyguard.com. Call me directly at 313-314-8267. I'd love to show you a demo. We connect to your favorite EMRs. We are here to help and serve you. We want to be an ally in the post-acute care space. In fact, Veronica, you're actually with me in about a week where I'm doing a keynote, and you're helping me debut this to the public.
Yes, I'm very excited. I'm very
So
excited.
it's I always tell people, right? Because a lot of people don't want to partner in this space. There's definitely enough room in business out here for everybody. We should be partnering with each other to elevate. So I got the Gym Scout there helping elevate Survey Guard because ultimately we're both passionate about improving quality outcomes.
Mm-hmm.
So that's what I got about Survey Guard. Before we switch over to the F tag of the week, any last minute words on that plan of correction, Veronica?
I will say that if you are doing monitoring, it needs to be documented. That 15-minute check, it needs to have the time. It needs to have where the resident is. It needs to have staff initials. The bottom should have a signature key. I have worked with facilities who had an elopement and put in, those Q 15-minute checks. And then when it came time to provide those to surveyors, the checks were very lacking. Resident names missing, staff initials missing. If it
Yes.
says Q 15-minute checks, every 15 minutes, the times need to be at least every 15 minutes with those initials. And so don't skimp on it. And the quotations, when that first person put dining room, don't follow up with the quotations each line. It just, we want to make sure it's tight. We want to make sure that this could be read by itself. If you handed somebody this Q 15-minute check, do they know what it is? Can they say where this resident was every 15 minutes and who the resident was with? And so, again, just making sure that if you're using those checklists as a intervention, that they're completed. When you do your elopement risk assessments, a lot of those, we have those UDAs inside of whatever EMAR you're using, EHR you're using, but just making sure that if you're filling it out and then they have what intervention was put in place at the bottom, that intervention makes its way onto the care plan. Because what happens is they'll say, we did 100% elopement audit, elopement assessment, and at the bottom it'll say care plan updated, and it'll say whatever they said.
Yeah.
But then when you go to the care plan, it's blank, right? And so also making sure that those care plan interventions also flow through to the Cardex, so that your frontline staff know that this person is, one, an elopement risk, two, the interventions. So just don't skimp out on this, right? And so again, that's what I'm going to say on that.
Well, we're talking about protecting your residents and even more protecting your license.
Yes.
Because what we love to say once again is we've done that audit, we've done that education, but then we put on the care plan, but we haven't educated the nurses on the care plan. Now, I'm a whole registered nurse. I play one on TV a little bit. It's a challenge for nurses to look at the care plans for everyone. We are required to provide care to the level of expectation, which means we are required to provide the care that the patients need and the care that's ordered. So if we're making updates to the care plan, we have to notify the staff. If there's a change, we have to have a systematic way to notify staff. It's not enough to just put an intervention on the care plan, but you didn't notify staff. So you talked about the Cardex. How do we notify staff that there was a change to the Cardex? How do we notify them?
Right.
That is some of the issues that we face. And I think that as leaders, we have a job to, once again, protect our residents. And when we protect our residents, we protect our license.
Very well said.
Let's shoot over to our F tag of the week. Let me get my little video together. Hold on. I had it pulled up and then I switched over to something else. It just cuts off. So we have two F tags of the week, and I have actually a beautiful PowerPoint that's going to go with this after this, but two tags, right? And we're doing F790 and F791. Both are about dental, and we don't talk about dental care and long-term care enough. And I'm be honest, when I read this reg, I was like, oh, I'm doing things wrong. I thought I knew. I'm doing what I've heard before, because there are two distinct regulations for our organizations, and one is for SNF 790 and then one is for 791. There's a clear difference of how and what you need to do for these residents, and it's only related to the financial component. They still have the same expectations. I don't know. Have you had a chance to look at them?
Yes.
What's your thoughts on? And we can start with 791. I can go a little deep on it, or if you want to lead us, it's up to you.
You can start and I'll jump in.
Yeah, so with 791 focuses more on SNF, right? And it says providers must obtain services from an outside resource. What was interesting about 791 is when I pull it up, let me bring it back over here. When I put it up, right, it's the same. We must be able to obtain services for routine care and then 24 hours for emergency dental. You cannot tell a resident they can't see a dentist because they don't have the funds. And this is for SNF or just regular long-term care.
Right.
I found that interesting. It also talks about we must have a policy identifying those circumstances when the loss or damaged dentures is the facility's responsible, and you cannot charge the resident if there is a loss or damaged dentures determined according to the facility policy. I've never seen a facility policy about lost dentures. I know when dentures have lost, they say, "Oh, we don't replace them." Well, where's your policy?
Yes, you're right.
It goes deeper to say your policy must be detailed about the investigation you did to determine that you weren't liable. Found that interesting. If you need an emergency, it tells you what prompt is. You must do something within 3 days. You must refer them. Doesn't mean you have to get the appointment, but you must refer them within 3 days. And you must ensure that the resident can still maintain their lifestyle, still can eat and drink adequately if you can't get them in quickly. So that is for Medicare, right? You can bill them for the additional money, but you have to make sure they're getting to their appointments and that you're arranging transportation for them. Now, for nursing facilities, when we're dealing with our Medicaid residents, this is where it gets a little interesting because you have a duty to ensure their same level of care, their same level of quality of life. So it's the same language you read here. Must get them care within 3 days. That is their routine dental care to the extent covered under the state plan. So if they have a Medicaid plan, to the extent of their Medicaid plan. So if the Medicaid plan will cover routine extractions, then you have to cover routine extractions. If the Medicaid plan covers dentures every X amount of months, years, you have to cover that. And it's very called out here. Once again, must have a policy for when the lost dentures are there. I found that very interesting. They go into a little bit detail about emergency dental services. And this needs to treat an episode of acute pain in gums, palate, broken or otherwise damaged teeth. I've been to so many buildings that don't have a dentist readily available.
Yes.
Promptly means within 3 days. Doesn't mean you get to it when you get to it. So if your social worker's on vacation, who's handling this need? Because I've heard people say social worker's not here. When she come back, we'll set you a dental appointment. Can you wait 3 days when you got a toothache?
No.
I know I can't.
Yeah.
So then it talks about having routine annual inspection. I've done mock surveys of building, and I'll ask them for their podiatry list, who's been being seen by podiatry or dental, and they will look at me like a deer in the headlights. You have to allow them to get new and repairs to their partials for denture adjustments, fixing or smoothing broken teeth. You have to allow them to do that. Now, it gives you some guidance here. Once again, I think it's important to talk about it, but I'm going to switch over to my PDF because my PDF makes it a lot easier for you guys to understand where we're going and how we're going to get there. So what I have on the screen is, once again, the two differences of what we're discussing. F790, which is for SNF, and then 791, it talks about it in great details. We're going to go over to what must happen. You must have a policy identifying loss or damage of dentures. If it's disposed on a meal tray, that is your fault.
Yes.
I can't tell you how many times builders say, "Oh, that's not our responsibility. They should have moved it." You cleared the meal tray.
Yes.
You didn't check the meal tray. You can't ask a patient to pay half of it. I've seen buildings where they say, "Well, we're going to ask the patient to pay half." The rules and regs say you can't do that. Wow. If it's your responsibility, you can't ask them to pay half. I think we need to call that out. It goes on to talk a little bit about the loss identified and when a referral must happen. This is important because I don't think we're moving this quickly. Have you seen us move this quickly?
No. No.
This is in the regs. And this is why we do this on the Survey Readiness Podcast, because we want to bring this information over to you. We want you guys to perform at top of scope, because once again, when you protect the residents, you protect your license. It's cut and dry for me. When you protect the residents, you get to protect your license. So as we navigate more through this and talk about this a little bit more, a referral means making the appointment or contact. It's not required as physically being seen in 3 days. But if you have a delay, you must document the extenuating circumstances as to why you didn't make that. We're back to documentation again.
Yes.
Now, I hadn't seen these type of tags turn into an F689 tag and turn into an IJ because we didn't do anything. So what happens between the referral and when you get there? Well, you got to make sure this patient can still eat. You don't get to say, oh, it's 2 weeks out and they didn't eat. And now you have a sig loss for weight. Am I right?
And then you got an F692, nutrition, hydration, weight loss, dehydration, poor dentition, missing dentures, unresolved dental issues. We can go down the list, right? F677 ADLs, because now they may not be able to eat, right? Quality of care, like it's just a cascade.
You look at this. You have to do something. And when you think you're out of resources, they even gave you more. They said, look, you can reach out to private dentists. You can go to dental schools. You can check a community clinic. There's no reason that you haven't exhausted all 3 areas before you say you could do nothing.
And document.
I mean,
of course, there are times, sometimes I've called dentist office and they'll say the next appointment is for 60 days, right? I'm going to make that appointment, but then maybe reach out to the community clinic to see if there's something sooner. Document that response, right? Then, of course, we're documenting those interventions. We changed the diet to a mechanical soft diet. We're providing pain medication. We're doing all of that in between time. So, of course, the documentation piece is going to be very important.
And you called it out. Now, you haven't seen this. I made this on my own, but you called it out. 692, 677. 636. We got a care plan assessment tag right there, right? We got Miss Meds potentially, depending on what it is. 757. Like, look at the ripple effect of not having good oral care.
Right.
You called it out without even knowing what was going to come next. People don't even think about the decrease in ADLs. But if I can't chew and I can't eat, what is that doing to my body? How is my body going to react?
And honestly, who's doing Section L? Your admission assessment, your admission MDS. Section L is your oral status, right? And they're asking, has this resident been admitted with broken teeth? Are they edentulous? Do they have a mouth pain? And so are we really assessing that? Because that's going to be the basis of everything going forward. So if they were admitted with these oral problems, what type of interventions have we put in place, right? And then if they were admitted with the oral problems or these oral problems pop up, surveyors are going to go look at that oral assessment. They're going to look at the last MDS to see what Section L had. And if it's not coded correctly, then you get into accuracy of assessments. That F636 you just talked about. And so if one is that way, they might start digging and see, a widespread problem that could rise to that level of IJ again.
They're going to do exactly what we got on the screen. Walk us through what's on this screen right here. They're going to do exactly this.
So, of course, the observation piece, does the resident have broken teeth? Do they appear in pain while eating? Are dentures missing? Then they're going to interview your residents, right? And what we talked about last week, if we're not communicating and talking to our residents and our resident families, when a surveyor comes and interviews them, it's going to be like lights, camera, action. They're going to pull out their best performance because they've never felt that people are asking these type of questions. Did the facility help you make the appointment? Did they charge you? Did you wait long, right? And so if we're communicating this issue with our residents, we called this dentist, they can see you in 60 days. I'm reaching out to these other people. So keeping the resident in the loop of what we're doing as well, so that when surveyors come in and ask these questions, they're not going to shrug their shoulders. And then they're already going to know that we're trying to remedy the situation. So then after the interview, your surveyors are going to do the record review. So they're going to verify that we, within 3 days of noticing these issues, that we've reached out for a referral, right? And then they're also going to make sure that we have any signed contracts with outside dentists. If you're using one of those dental groups that come in to the facility, how often are they coming? What is the list of people that have been seen? Are the people being seen annually and in between if they have issues? And so again, when they start looking at those lists, it could really open a can of worms if your processes are not in place.
Definitely from the standpoint of records review, you talked a little bit about more of Section L. I'm not I don't do MDSs. We do MDSs at SMK Medical, but that's not my area of expertise. Would that be a sick change if they can't chew? What do I need to do? How does that work? What care plan do I need to update? What does that look like if a patient can't chew?
If this is affecting more than 2 areas, so let's say we had a SIG weight loss, right? They have the mouth pain. I'm going to open a significant change, because what the significant change MDS does is it triggers a care plan update. It triggers the IDT team then to have to do the care area assessments, right? And so it's going to alert your whole IDT team that something is different with this resident. And now let's look at the entire care plan. Do we need to update the activity plan? Because now the resident can't eat popcorn at an activity. They may not be able to participate the same way in activities. A dignity issue. Maybe now they're self-conscious to the point where they don't want to come out. It could lead to social isolation. Weight loss. Are we having to change the diet texture? Mechanical soft, a puree diet. Are we having then, because of weight loss, having to provide nutritional support through oral supplements? And so that significant change just lets everybody know we need to take a microscope and look at how these issues are affecting this resident.
At the end of the day, we want you to tax somebody who needs to hear this, but we want you to protect your residents because we want you to protect your license. We're going to go ahead and coin that phrase. Protect your residents so you can protect your license. And ultimately, if you listen to us today, I want you to take 3 things away from this particular FTAG, right? Financial clarity is a must. Is it a SNF or an NF? SNF, you can build a resident. They have Medicare. You can bill them. They do what they need to do. But NF, it is your responsibility. You accept the patient as a whole. Back in school, they talked to me about holistic care. You have to provide holistic care. Number 2, you have to have referrals that are prompt within 3 days. You must do that. And then 3, there's the holistic work, right? You have to bridge the care gap, as Veronica talked about, with the diet and plan management, care plan management. So we talked about it. We gave them the sauce.
We gave it to them. All the sauce.
Because this podcast, right, we focus on leadership, compliance, risk, and strategy. That is our core foundation of what we do here on the Survey Readiness Podcast. Every 2 weeks, we're going to come to you with a different FTAG, a different plan of correction, because we don't want you to make some of the same mistakes that we've made, or the issues that we are finding in these plan of corrections. Right? We should be able to learn from each other. We should be able to grow from each other. As I mentioned, I'll be I'm the keynote of Leading Age Oklahoma coming up at the beginning of March. I'll be at a pack-in as well at the end of March. They be on Survey Guard to a pack-in. Actually, Veronica, I think you speaking at Oklahoma. Am I correct?
Mm-hmm.
What's your topic?
At Leading Age on the home care home run documentation in home care.
She don't play like everything. So she's speaking there, and then you got a couple keynotes lined up this year. Am I correct?
I will be at Iowa Healthcare Association next month, end of March. I will be doing a keynote there, also speaking about some risks, mitigating risks in assisted living as well.
Yeah.
In April, I will be in Oregon speaking, not a keynote, but we'll be at Oregon Healthcare Association speaking. And then May, Care Providers of Oklahoma. So on the road, looking forward to seeing everyone, sharing some good information with you. Definitely looking forward to connecting with you, DJ, in 2 weeks or less. So just appreciate the partnership, the collaboration. And again, we talked about this in real life. You don't have to do this alone. Okay. And so partnering up with other DONs, other administrators, following people like myself and DJ for these great tips, because when you win, we win, and the residents win. And so that's as long as we're keeping them first, just partnering up. You don't have to do this alone. And so I'm grateful to be able to share this information with our audience.
How did they reach you?
VeronicaCaesar.com. You can find my free survey ebook. There are also some free antipsychotic QM downloads on there. There's a free antipsychotic hybrid, the new antipsychotic hybrid QM measure. There's a quick video on there. My contact information is on there, VeronicaCaesar.com, or you can email me at Veronica@VeronicaCaesar.com.
Hey, I love it. I love it. And we want you, of course, to like and subscribe to this podcast, the Survey Readiness Podcast. It is on YouTube. We are streaming live on LinkedIn. I was just checking when you were talking. We do have a few people watching on LinkedIn, so shout out to our LinkedIn guests. We're streaming on Facebook, but we're also iHeartRadio, Apple Music, Alexa, so much more. And simply hit that search button and search for the Survey Readiness Podcast. As you know, once again, my name is Dr. Demetrius Kirk. I am the founder, the CEO of SurveyGuard, a platform dedicated to the post-acute care space, here with my co-host, Ms. Veronica Caesar, and we are here to just inspire. We are here to promote excellence in the post-acute care space. We are dedicated to compliance, risk management, and quality outcomes. And I think as long as we lead with that, we will see a better field. We will see a better, landscape in our area. So, thank you again for joining me. As always, we will be back here in about 2 weeks with a new plan of correction and a new F tag. Until next time, stay survey ready.